आप सबको मेरा सादर प्रणाम. Pediatric heart failure is associated with considerable morbidity, mortality, and financial burden. Therefore, early recognition in emergency settings is important to prevent mortality. In this video, I shall be discussing the latest national treatment guidelines by the IAP for the management of heart failure. I have as well included information from some other resources of IAP to present a comprehensive package for you. But prior to that, if you are someone who wants to stay updated with the latest, who wants to have conceptual clarity, who registers better with illustrations, who wants to have a succinct summary of most of the topics, and who wants a ready, reliable reckoner, then this channel is certainly the place for you, and I urge you to subscribe to the channel for the above benefits. So pathophysiologically, if we see, cardiac failure basically results from structural or functional defect in the heart, and it results in impaired atrial filling or impaired ventricular emptying. It is defined as a syndrome with clinical and pathophysiological implications which occurs when the heart is unable to meet the metabolic demands of the body. So pathophysiologically, if we try to understand, we see that oxygen to the tissues, delivery of oxygen to the tissues is basically dependent on the cardiac output as well as the amount of oxygen which is present in the blood. Cardiac output is in turn a determinant which is determined by heart rate as well as the stroke volume. Stroke volume in turn is determined by preload or ventricular filling, contractility of the heart, that is myocardial contractility, as well as afterload, that is resistance to the forward flow of blood. Now if we see that cardiac output is proportional to the filling volume, that is preload, and is inversely proportional to the pressure against which it has to work, that is the afterload. So basically what happens is that this is the Frank-Starling curve, and here you will see that initially as the ventricular preload increases, the stroke volume also increases, but in failing heart, as the ventricular preload increases further, the stroke volume fails to increase, and in this way, this is for example seen in conditions with volume overload, for example left to right shunt. So physiologically, we categorize heart failure as that seen in patients with ventricular dysfunction and that seen in patients with normal ventricular function. So patients with ventricular dysfunction can fall into two categories. First is a normal heart, like patients suffering from myocarditis, arrhythmia, ischemia, cardiomyopathy and drugs, or a heart with structural defect, for example congenital heart disease with increased pulmonary blood flow, for example the left to right shunts which I was just talking about. Or patients even with normal ventricular function can land into heart failure in cases where there is volume overload. Again, left to right shunt, valvular insufficiency, especially in older children with the rheumatic heart failure, rheumatic heart disease and fluid overload conditions, and pressure overload conditions, for example right-sided lesions like pulmonary hypertension and pulmonary stenosis, and left-sided cardiac lesions like coarctation of aorta and aortic stenosis. So clinical features, basically the symptoms and signs arise due to reduced cardiac output and or volume overload, and this may vary with age. So infants, they present primarily with tachypnea, irritability, feeding difficulty, which is manifested as the suck rest suck cycle. The infant feeds onto the mother's breast, tries to suck, but then he wants to take a pause and rest for a while because he gets dyspneic, and then he again tries to suck. Feeding diaphoresis or sweating on the forehead while feeding, because the heart has to work during the feeding process. It has to increase the blood supply to the muscles of swallowing, and failure to thrive on a long-term basis. Common clinical features seen in children are cough, dyspnea and chest pain, easy fatigability, syncope and abdominal complaints. Congestive features can be both systemic as well as pulmonary. So systemic features are fatigue, altered mental status, decreased urine output, nausea and vomiting. as well as cold extremities. Common signs are cold extremities, low volume pulse, prolonged capillary refill time, hypotension, decreased urine output, and altered mental status. The symptoms of pulmonary congestion include dyspnea, orthopnea, that is dyspnea on lying down, paroxysmal nocturnal dyspnea, cough, wheezing, feeding difficulty, feeding diaphoresis or sweating during feeding, especially in infants, and abdominal pain. Common signs are increased work of breathing manifested as respiratory distress, retractions and tachypnea, elevated jugular venous pressure, cardiomegaly, basal crepitations, wheeze, and tender hepatomegaly. There are 4 stages of acute decompensated heart failure, as we would see just now. And first stage is, this is characteristically taught to the fellows of the pediatric intensive care. So the first stage is wet and warm, in which there is systemic and or pulmonary congestion. The second phase is wet and cold, in which there is peripheral vasoconstriction. Next stage is dry and cold, in which the cardiac output decreases. And finally, there is a stage of dry and warm, in which can be achieved if we institute drugs like diuretics and inotropes. So our aim is to achieve up to at least this stage, dry and warm stage. From wet and warm, we need to achieve the dry and warm stage. For evaluation, one must ask the history of fever, rash, joint pain, abnormal movements, which would be suggestive of patients having acute rheumatic fever, rheumatic heart disease. A history of scorpion sting is also very important in patients with heart failure of unknown etiology or without previous signs and symptoms. And poisoning or ingestion should also be ruled out, especially patients with aluminum phosphide poisoning. Risk stratification was classically done by the New York Heart Association classification, and this kind of severity classification was based on the ability of the patient to perform an activity, for example walking. So as per this, class 1 is no limitation of activity even with ordinary activity. Second is mild limitation on ordinary activity. Third class is marked limitation on less than ordinary activity. There is limitation is marked and activity is less than ordinary. And in fourth class, symptoms occur even when the patient is taking rest. So this classification was not much of use, especially for infants, because they aren't even walking. So a modified Ross classification was devised for infants, and this is basically based on the breathing difficulty or the dyspneic features. So as per this, class 1 is when an infant is asymptomatic and there is no activity limitation, and the child is also asymptomatic. In class 2, there is mild tachypnea and sweating while feeding in an infant, and there is dyspnea on exertion in a child. In stage 3, there is marked tachypnea, sweating while feeding, and growth retardation in an infant, whereas in a child there is marked dyspnea on exertion, as well as the child may be developing failure to thrive. Class 4 is when marked symptoms occur even at rest and there is failure to thrive. So basically the difference between NYHA and the modified Ross classification is the parameter which has been taken, in that the ability to perform an activity was considered, and here the breathing difficulty is considered, even though the base remains the same. That is no limitation in class 1, mild limitation, moderate limitation, and marked limitation in class 2, 3 and 4 respectively, and class 4 symptoms occur while the patient is even on rest. So what are the emergency room diagnostic tests we need to perform in a patient or a child who is presenting with heart failure? Include blood gas to rule out hypercapnia, hypoxia, lactic acidosis and electrolytes, complete blood count to rule out anemia and to look for any evidence of infections, ECG to rule out arrhythmia, myocarditis in specific conditions like Al-Kappa and acute rheumatic fever, chest x-ray to look for cardiomegaly, pulmonary plethora and specific shapes of heart of the specific types of congenital heart disease. Then C-reactive protein and procalcitonin in patients suspected with sepsis and acute rheumatic fever, as well as Kawasaki disease. ESR in patients with AKI and Kawasaki disease. KFT in patients with AKI and chronic kidney disease, LFT in patients with congestive hepatopathy, cardiac markers to look for evidence of myocarditis, heart failure, troponin I, CPKMB, and pro-BNP. Point of care ultrasound also needs to be done. This is the latest technology in our armamentarium, and this is very useful. I shall soon be making a video on the same as well, because it gives us a bedside evidence of fluid overload manifested as confluent B lines, distended inferior vena cava, cardiac. It gives us an impression about the cardiac contractility, ejection fraction, and cardiac index for those people who are interested in knowing the details. And an echocardiography, not necessarily in the emergency room, but yes, should be performed to make a definitive diagnosis of the suspected congenital heart disease, because most of the time infants are suffering from congenital heart disease. The classification of heart failure based on the left ventricular ejection fraction is as follows. Here, the first category includes heart failure with reduced ejection fraction, that is less than 40, heart failure with mildly reduced ejection fraction, that is between 41 to 49, and with preserved ejection fraction more than equal to 50, and with preserved ejection fraction which is improved, that is prior it was less than 40 but now it has become more than equal to 40. So this particular classification, I guess, is more important for the cardiologists and is of less use for us as pediatricians. For deciphering etiology, we definitely need to perform a chest X-ray to look for cardiomegaly, pulmonary vascularity, and pulmonary edema. Egg on end appearance is suggestive of the transposition of great arteries. A snowman appearance is suggestive of supracardiac TAPVC, and a money bag appearance on chest X-ray is suggestive of pericardial effusion. These are the common anomalies which you can rule out. Then an ECG, a bedside ECG, is also important because it helps us to look for enlarged chambers, arrhythmias, and electrolyte abnormalities, common electrolyte abnormalities. Hypertrophic cardiomyopathy is, for example, seen in Pompey's disease, and ischemic changes are characteristic of Al-Kappa. Then an echocardiogram helps us to look for ejection fractions, structural heart disease, enlarged chambers, and pulmonary artery pressures. And some other optional investigations include cardiac MRI, cardiac catheterization studies, angiography, endomyocardial biopsy, and biomarkers, which I had already described in the emergency room investigations. So the initial management, as in any other case, comprises of management of airway, because the patient may require intubation and positive pressure ventilation. Children with pulmonary edema may require airway clearance by frequent suctioning. Breathing, which includes providing high PEEP, because this may help reducing pulmonary edema, decreasing afterload, and improving cardiac output. The circulatory status management has been discussed in a subsequent scene. Besides this, disability management, and you must also expose the patient to look for other stigmata of other common etiologies. Since circulatory management is the important thing in the management of heart failure, I would like to stress that a small Aliquot bolus of 5 to 10 ml per kg can be given slowly over 1 hour to restore the intravascular status in patients with shock. But a large amount and rapid bolus should be avoided at all costs. Point of care ultrasound should be utilized to guide further fluid therapy and inotropic support, as well as look for cardiac contractility. If on focus you find that the cardiac contractility is poor, early inotropes in the form of dobutamine, adrenaline, milrinone can be started to improve perfusion. Beta blockers should be avoided in children with decompensated heart failure. Here I would like you all to know that dobutamine and milrinone are inodilators, that is, they have inotropic action as well as vasodilatation action as well. So basically they increase the cardiac contractility as well as reduce the afterload of the heart. If you want to know a detail of these terms, I have mentioned in this and described them in detail in previous videos of mine, the links of which I shall be sharing in the description box below. So if the patient is not in shock and cardiac contractility is good on focus, then diuretics are used to decongest the accumulated fluids, and maintenance fluid should be restricted to 50 to 60%. So here you see there is an entirely there is almost a specific approach to so it is only after recognition of whether the patient is in congestion or not that you shall be able to manage the shock better. As general measures are concerned, the first and the foremost important thing is that you must place the patient in semi-Fowler's position, that is the head and torso at 15 to 45 degrees. Provide respiratory support in the form of oxygen and positive pressure ventilation in patients with pulmonary edema. Fluid restriction in patients with edema and associated hyponatremia. Anemia correction with PRBC. Correction of secondary causes, which I shall be discussing in subsequent scene. And tube feeds should be started as soon as the patient becomes hemodynamically stable. Later on, we must continue the patient to have bed rest, provide energy dense formula with 120 to 150 kilocalorie per kg per day or up to 24 calorie per ounce of a formula to meet the demands of the hypercatabolic state, and supplement appropriate calcium and vitamins. In patients with chronic decompensated heart failure, for example, adolescent patients with rheumatic heart disease, rather mild to moderate exercise is recommended and normal diet can be given as per these guidelines. So the secondary causes which I was talking about in the previous scene include specific treatment. So these include hypertensive emergency requires institution of labetalol or sodium nitroprusside infusion. Management of severe anemia requires PRBC transfusion as seen earlier. Management of renal failure and fluid overload requires fluid restriction, diuretics and renal replacement therapy. Thiamine deficiency or wet beriberi, which is not a very common cause of heart failure, includes thiamine supplementation. But in patients in which you are not able to decipher the cause, it is better to supplement thiamine. Scorpion sting, you give prazosin and to the management of the same. Kawasaki disease, viral myocarditis and multi-inflammatory systemic syndrome, you need to give IVIG. Arrhythmias, you give adenosine or amiodarone. Cardiac tamponade, you perform pericardiocentesis. In aluminum phosphide poisoning, you consider ECMO. And in patients with, you must consider giving ventricular assist device in patients who are awaiting heart transplant and who are refractory to all medical management. Advanced heart failure is defined as patients with functional class 3 to 4 symptoms despite optical medical management. That is, patients who are having dyspnea on moderate activity and who have moderate limitation, and class 4 is marked dyspnea or at rest itself or marked limitation on rest itself. And this is characterized by severe cardiac dysfunction, more than one hospitalization or unplanned emergency room visits more than one time during the past 1 year, and severe impairment of exercise capacity. Commonly used drugs include diuretics, which is the first line of drugs because they reduce systemic and venous congestion. Loop diuretics interfere with sodium and water absorption. Thiazides act on distal convoluted tubules. Aldosterone antagonists are mild diuretics, but they have a cardiac remodeling action as an additional advantage. And SGLT2 inhibitors like dapagliflozin and empagliflozin interfere with sodium absorption. Drugs which reverse modeling include ACE inhibitors and angiotensin receptor blockers. They reduce afterload and prevent myocardial fibrosis. They are useful in severe MR, that is mitral regurgitation, aortic regurgitation, cardiomyopathy, and left to right shunts. ARNI, that is ARB plus neprilysin inhibitor, are useful in heart failure with reduced ejection fraction to less than 40. Adrenergic receptor blockers should not be administered in patients with acute heart failure, as we had already seen that beta blockers are contraindicated. And phosphodiesterase inhibitors like milrinone are used in conditions with low cardiac output and post-operative cases. They are used as adjuncts with cardiac inotropes because they are basically inodilators. So these are the commonly used drug classes which we had just seen earlier. So these include loop diuretics like furosemide and bumetanide, thiazide diuretics like hydrochlorothiazide, aldosterone antagonists like spironolactone and eplerenone, adrenergic agonists like dopamine, dobutamine, epinephrine and norepinephrine. Then milrinone is also an adrenergic agonist. Then afterload reduction agents like ACE inhibitors, angiotensin receptor blockers, ARNI, that is sacubitril valsartan, metoprolol, carvedilol, nitroglycerin and nitroprusside. Then some other miscellaneous drugs like levosimendan, SGLT2 inhibitors like dapagliflozin and empagliflozin, digoxin and ivabradine. Many people have been saying that digoxin is out of use and is now contraindicated, but I haven't read, after going through many literature, many books on heart failure in children, I haven't come across this statement anywhere. Yeah, definitely it is contraindicated in patients with ventricular tachycardia, hypertrophic cardiomyopathy, AV block, and the side effects are also prominent, including AV block and GI disturbances. But a lot of caution and monitoring is to be exercised while giving digoxin. One must monitor heart rate and rhythm because the child is at risk of arrhythmia. Improvement in heart rate indicates a response to treatment, whereas persistent or worsening tachycardia indicates a failure to the given treatment and indicates further assessment. Besides, capillary filling time and pulse volume, JVP, bilateral crepitations, and hepatomegaly, strict input-output charting for fluid balance should be looked for. Electrolyte monitoring should be done every 6 to 12 hourly, including sodium and potassium. POCUS for inferior vena cava diameter and cardiac contractility is a latest and a really very useful tool for bedside monitoring. So the ready reckoner includes all children, especially infants presenting with respiratory distress in the emergency room. Heart failure should be suspected and should be ruled out in them. Severity classification helps in the prognostication of heart failure. Airway, breathing, circulation and disability stabilization is a priority in children with heart failure. POCUS is an important tool and strict fluid charting and electrolyte monitoring is required. Secondary causes should definitely be identified and treated because otherwise the patient will not be completely out of danger. Thank you so very much for a very patient listening and watching, and thank you for all the love and support that you've been showing to this channel. Thank you, thanks a lot. If you have any questions, I request you to write in the comment section below, and if you did like the video, please give a thumbs up because it acts as an encouragement for me. Thank you.